So we'll go through this case of a traumatic cataract and just my approach to it, and yeah, if you could comment along the way, and then we'll hand over to Heiko. Now this particular case is a blunt trauma, and the patient developed a subsequent cataract, and on the A scan it turned out they had significant astigmatism. So the plan was to not just take the cataract out, but also to put a toric intraocular lens to correct this astigmatism. So this is just the toric IOL marking process. So the patient's been pre-marked at the slit lamp before the surgery, and then in surgery we use a Mendes gauge and a marking device. So this just orientates the toric intraocular lens in the right position when we get up to that stage. I know you're not a big fan of the toric intraocular lenses, but I feel that patients are becoming more and more demanding in terms of their visual outcomes, and more of them want to have uncorrected visual acuity or low dependence on spectacles. So yeah, I like to put these toric lenses in, particularly if the astigmatism is more than 1.5 diopters. So with this sort of case, you can see that even after attempted pharmacological dilation, that the pupil's still very small, and that's part of the challenge with these sort of cataracts. You definitely need a large pupil and good visualization, because you know that the zonules are going to be compromised, and you may clinically, before surgery, sense a degree of phacodenesis, but I find that sometimes you just don't know how much phacodenesis there is until you're actually operating it, until you're actually feeling the lens inside the eye and just feeling how unstable it all is. So I'm using Duovisquit, which is a combination of Viscoat and Provisc, and I like to use a soft shell technique, so I can push that Viscoat onto the endothelium and coat the endothelium to protect it, because a lot of these traumatic cataract cases they're definitely not routine cases. You need a lot more time on your surgical list for them, because they do take longer, and also because of the longer procedure, you definitely need to give the endothelium more protection. If you enjoyed this lecture so far, please subscribe to http://iop.vision. I hope you enjoyed this series as much as we have putting it together. Thank you.